Moving forward, our next speaker is Dr. Moira Szilagyi. Dr. Szilagyi is a primary care pediatrician, advocate, educator, and professor of pediatrics at UCLA, where she is interim division chief of general pediatrics and chief of developmental and behavioral pediatrics. She completed her MD, PhD, and pediatric residency at the University of Rochester and spent 30 years of her career there. While in Rochester, she developed a community-based integrated care medical home for children in foster care. Dr. Szilagyi led the development of the first healthcare standards for children in foster care in New York State, Fostering Health, which has become a national standard. Her work within the AAP is equally extensive and impressive. She's had leadership roles in the section, task force, and council on foster care, adoption, and kinship care within the AAP. Dr. Szilagyi works closely with the AAP's Washington office on legislation related to equity, diversity, and the care of vulnerable children, collaborates with mental health and child welfare to integrate evidence-based interventions into pediatric care, and currently leads a federally funded multi-site project with the AAP and UMass to educate pediatricians about trauma-informed care. It goes without saying that she's a nationally renowned expert in childhood trauma and trauma-informed care. We look forward to her AAP presidency in 2022. Please welcome Dr. Moira Szilagyi.
Hello and welcome. Thank you, David, for that wonderful introduction. And I want to begin with a special thank you to all who made our first virtual NCE happen. It has not been a small undertaking. My name is Moira Szilagyi, and I am going to speak today about one element of trauma-informed care, which is providing a safe, stable, nurturing environment for all children. I have no disclosures, and at the end of this brief talk, participants should understand the importance of the primary attachment relationship in preventing and ameliorating trauma and its impact, and promoting healing from trauma, and the role of the pediatrician in promoting safe, stable, nurturing caregiving. I assume that most of you are familiar with the Adverse Childhood Experiences Study published in 1998. This study linked the dose of intrafamilial trauma and adversity in childhood and adolescence to poor health, mental health, and social outcomes decades later. Subsequent studies have upheld this relationship and the high prevalence of ACEs, which affect about 2/3 of all children, even those in seemingly low-risk families. Cumulative adversities that occur outside the family have also been linked to poorer outcomes and include poverty, violence, and felt discrimination. In recent months, we have certainly borne witness to the suffering caused by racism in all of its forms. In 2012, the AAP published the Toxic Stress Policy Statement. This paper described how ACEs and other adversities cause an unrelenting activation of the body's stress response systems in the absence of buffering caregiving. This leads to changes in immune function, gene expression, and brain architecture. Thus, life course science now explains how ACEs in childhood can become biologically embedded and lead to poor outcomes in childhood and decades later. We also know that individuals can emerge resilient or with minimal symptoms, or with both body and brain symptoms. And brain effects can include developmental, emotional, behavioral, or cognitive development. But adversity is not destiny. Symptoms depend on the severity and duration of the trauma, the child's genetic profile and developmental stage, and the availability of those buffering relationships. In fact, research indicates that the single most important protective factor for a child is having at least one safe, nurturing caregiver who is stable over time in their life. As pediatricians, how do we respond to this information? The short answer is trauma-informed care, defined by the National Child Traumatic Stress Network as care in which we recognize, assess, and respond to the effects of trauma on children, families, and on ourselves. In the near future, the AAP will publish a policy statement and a clinical report on how we can effectively and efficiently do this work in pediatric settings. The good news is that trauma-informed care builds on the resilience-promoting care we already provide every day, with some additions and modifications. First, let's consider what we mean by resilience. Dr. Ann Maston, a developmental psychologist, defines resilience as positive adaptation to or in spite of adversity. And 8 decades of research have identified at least 7 personal factors or threads that weave together the fabric of a resilient human being. They are having a thinking and learning brain, hope, optimism, or faith in the future, regulation of behaviors and emotions, self-efficacy or the sense we can control or impact our future or environment, positive or secure attachment relationships, mastery of age-appropriate developmental skills, and connection to a larger social network. Dr. Maston describes resilience promotion as ordinary magic, a term I love, because for children, resilience develops in the give and take of safe, stable, nurturing relationships that are stable over time, and in the growth that occurs through play, exploration, and exposure to a variety of typical activities and resources. Thus, resilience research has identified the remarkable power of the ordinary in human development and the centrality of the attachment relationship. A safe, stable, nurturing caregiver serves many functions for a child. They provide a secure base from which the child can safely explore the world and relationships, develop their sense of self, and their sense of self in relation to others. This relationship is, in fact, the template for all of our future relationships. It is also the home where we develop our emotional self-regulation. It begins when a distressed infant is soothed by a parent, dampening the infant's stress response. The caregiver co-regulates with the child, models and teaches emotional and behavioral self-regulation as the child matures over the next 2 decades. The same process occurs with the scaffolding of executive function skills. The caregiver initially provides these skills, then models them, teaches them, and helps with them as we progressively master them. We also master age-salient developmental skills and begin to develop our sense of self-efficacy and competency in the care of a responsive, attuned caregiver. Trauma, however, can fray the threads of resilience. In the relative absence of responsive caregiving, stress hormones favor the brain structures for survival. Our limbic system, ever on the alert for danger and quick to react, develops in preference to the higher brain structures involved in learning and self-regulation. This leads to symptoms we commonly see in traumatized children and is described by the acronym FRAID. We see frets and fear, regulation disorders, relationship difficulties, yelling such as tantrums or aggression, and yawning, sleep disorders, educational and developmental difficulties, or even a child who is defeated, depressed, or who dissociates. Experts are landing on the term developmental trauma disorder to describe the impact of toxic stress. When buffering is available, we may see a child who is asymptomatic or who has only minor symptoms, such as sleep issues. Children with toxic stress, however, can present with functional, developmental, behavioral, emotional, and relationship difficulties. When we identify risk factors or see symptoms, even minor ones, we must consider trauma as part of the differential diagnosis so we can correctly diagnose and intervene so that healing can begin. If we do not, trauma can continue to biologically embed. Healing can occur because the brain remains malleable in response to its environment, especially during childhood, but throughout adolescence. In 2016, with funding from the Substance Abuse and Mental Health Services Administration, we formed a team, the Pediatric Approach to Trauma Treatment and Resilience, or PATTER team. Partners from UMass, UCLA, and the AAP have built curricula and developed resources to help pediatricians promote family and child resilience by focusing on the child's attachment relationships. Some families just need a little guidance from us, while we need to increase our support and have a larger sewing kit to repair the frayed threads in others. Most of us did not learn very much about attachment during training. However, we intuitively assess, use, and promote it in almost every encounter because we know of its crucial importance to children. The upcoming clinical report describes approaches we can use when there is or has been trauma to promote this vital relationship for all children from newborn to teen. Patter also highlights positive parenting strategies that we can use with all families, including those with trauma, to build nurturing, responsive caregiving. Let's look at a few. Serve and return. This begins with a back and forth gazing and cooing between a responsive parent and their newborn. It is critical in building the brain's foundational circuits. With most parents, we reinforce this by praising their warm, responsive style and discussing its importance in building healthy brain architecture. For the overwhelmed parent or mother with depression, we may need to point out the infant's attempts to engage them and teach the parent how to respond. Serve and return eventually evolves into attuned back and forth interactions and conversations between parent and the child or teen. Serve and return is in essence time in, and we already advise time in for all families. We encourage family meals and reading, talking, singing, and playing with children because time in nurtures both the parent-child relationship and healthy brain development. Special time in is a trauma-informed variation that involves the adult intentionally setting aside 15 to 20 minutes each day to spend with the child in child-chosen and child-directed play. For a traumatized or a highly stressed parent, we may need to start out with 2 to 3 minutes a day and gradually increase the time. The 3 R's, reassurance of safety, routines, and regulation. In this picture, a lot is going on. The caregiver is reassuring the fearful child of safety through holding and a soothing tone of voice. Not only is the caregiver dampening down the stress response, he is promoting a sense of security, co-regulating with the child, and likely using words to build the child's emotional vocabulary skills. Children learn about their emotions from responsive caregivers who reflect their feelings back to them while psychologically holding them, offering empathy, and naming the feelings. The RULER acronym reminds us that children need to learn to recognize and understand their emotions, which labeling helps with, and then to express and regulate them. Parents also help children to learn regulation skills by being an emotional container, able to hold a child's strong emotions while remaining calm and supportive, at least on the outside. This works for all ages. It helps to de-escalate the child's stress responses and move them from flight or fight into their thinking and learning brain. We can also help caregivers who have their own history of trauma or are dealing with multiple stressors. They may have difficulty attuning to their child or being an emotional container for them. We can empathize with them through attuned, attentive listening. We can acknowledge how challenging the job of being a parent is. By recognizing that the parent is the expert in their child and their family, we can partner with them in seeking workable approaches to their concerns. We can break down the long staircase of building responsive parenting skills into smaller steps the parent can achieve with our support. We can notice and compliment the parent who responds sensitively to their child during a visit and use it as a teachable moment. We can also teach the parent about catching the child being good and offering the child specific praise. We can frame an infant's or child's signals in terms of their development and help the parent interpret what the behavior tells us about the child's underlying emotions and thoughts. We talk a lot about routines in pediatrics. Initially, the newborn upends caregiver schedules, but the adult over time has to take advantage of the child's rhythms and the lengthening time between feeds to establish sleep habits and a meal structure. COVID has reminded us all of the importance of reestablishing or developing new routines to restore a sense of safety, predictability, self-efficacy, and self-regulation in our own lives. Sleep is almost always disrupted in traumatized children. Bedtime routines may indeed need to be enriched for a period of time. We can advise parents to spend more time settling the child down and reassuring them that they are safe. Caregivers can leave a family picture or a special lovey with the child to remind them they are loved and that the parent is nearby. We can also prescribe self-calming techniques for the child and the caregiver: deep breathing, imagery, exercise, rhythmic motion such as swinging, music, and meditation. Sesame Street and Communities has a number of short videos on belly breathing, talking about stressful feelings, and creating a safe nest or space for a child. When parents are challenged or have their own trauma histories, We can check in with them more often, build skills more slowly, be their champion, promote self-care, and link them to resources in the community, including parenting and mental health resources. We can also remind them that as they acquire new skills, such as establishing routines, child behaviors may escalate briefly. This is not failure on their part, but the child adapting to the new normal. In pediatrics, we meet families early and we see them often. We can leverage the beauty of our continuity of care relationship to promote safe, stable, nurturing caregiving to build or rebuild family and child resilience over time. For together with parents, we are the magicians who make ordinary magic happen. Thank you.